when Professor Giuseppe S. is online. So again, once more, thanks for the organizing committee for inviting me. It's really a pleasure to be here. Thanks, Professor Hisham, and thanks, Professor Nermeen Mustafa, for all the effort and all the team back on stage that kept up on the digitalization to come up with this part. So this is my disclosures. And actually, I'd like to kick off the presentation with some of the infographics about my patient. She is 70 years old, having only hypertension as a comorbidity. Her family history is irrelevant. However, in August 2015, she was diagnosed with early right breast cancer, underwent right wide local excision and axillary evacuation with a T2N0M0. It was invasive duct carcinoma of a triple negative breast cancer, and at that time she received the classic adjuvant setting for her treatment, the 4AC followed by 4 cycles of Taxotere, and that was followed by post-operative radiotherapy. So she was kept under follow-up until May 2020, where she was actually coming on the regular follow-up with annual mammography free, everything is free. And in May 2020, she presented with dyspnea and cough. And well, in the COVID era, everyone will go for the pulmonologist. They will ask for the non-contrast non-contrast CT chest, okay, because we are talking about COVID-19, there is the serine. So the CT chest showed pleural effusion and bilateral pulmonary nodule, and as well she went and did the PCR that was negative. So the question, what shall we do next? Actually, we started with a clearer view of the lesions. We did the PET-CT, and in the PET-CT it showed 2 hepatic focal lesions. The largest is 1.7 with a SUV of 11.16. It had a hilar lymph node with a SUV 4.8, few tiny bilateral nodules, and right minimal pleural effusion. With mild increased FDG uptake as well of the anterior end of the 6 and the 7 strip that was most likely post-traumatic sequelae. We did an ultrasound guided biopsy of the hepatic focal lesion that proved to be metastatic adenocarcinoma of a breast origin, and again the hormonal profile, the estrogen, the progesterone, all were negative, so it was having the label of a triple negative breast cancer. So, the first question, and that's in light of what we already heard. We have a 70 years old lady, performance status 1, having hepatic focal lesions, mediastinal pulmonary, and a triple negative breast cancer. Would you dig more and to try to understand and try to request more about the histopathology? Yes or no? And that's a question to the panel. So, Professor Yosri Rostum. It should work now.
So this is Giuseppe speaking from Milano. So
yes, I would go for more immunohistochemical studies, and I would go for BRCA mutation to see what is the situation here.
So, Professor Hisham would like to comment?
I think Professor Giuseppe.
Professor Giuseppe was on. Professor Giuseppe, you would like to?
Oh, yes, I am here. So the idea, so this was a triple negative at diagnosis. I would test, of course, the PD-L1 expression on the primary tumor. If you want, you can do also the determination of ER, PGR, and HER2 on the liver met, but I expect will be a triple negative. So it will be more useful to determine PD-L1 on the primary tumor, because if PD-L1 positive, she can receive a first-line treatment with atezolizumab and nab-paclitaxel.
Yeah, exactly. That's because actually we were thinking that it's another primary because of the 5-year span between the initial presentation in 2015 and the second one in 2020.
May I ask Professor Giuseppe, do you feel that there is may affecting the results the site of biopsy from the liver or from any place else? Because there is some comments from pathologist Professor Vialli saying that the site may matter. So do you feel that the biopsy from the liver may affect the PD-L1 expression, or it is different than other sites?
Yes, usually you have less expression of PD-L1 in liver mets because there are less lymphocyte infiltrating. So also the site of metastatic disease can affect the results of PD-L1, and this has been demonstrated in several trials. And liver mets usually are less immunogenic.
But Professor
Can I say something here also? Am I with you?
Professor Nagy.
Yeah, sorry, I was interrupted exactly when I was going to talk about this, electricity and connection problem here in Lebanon.
No problem, sir.
Yes, definitely, I agree to do a germline mutation and also the PD-L1. I was going to talk actually about the impassioned, study and also about the keynote 355 and I guess you might talk about them now, for using atezolizumab with nab-paclitaxel or also the pembro with other combinations as well.
Professor Giuseppe, considering the large time between the two diagnoses, because the initial triple-negative breast cancer was diagnosed in 2015, and the second one, which was considered in 2020, so this is a 5-year span. Here we don't, would you go to the initial pathology and do the PD-L1 again on the 2015, despite that you know that this is a larger span between the two diagnoses?
Personally, if you have to select the patient for immunotherapy, I would test the PD-L1 both on the actual site of disease, but also on the primary. Because if you look at the data of the inpatient 130, most of the patients assessed PD-L1 on the primary tumor, and the treatment-free interval was more than 1 year in any case. But I agree with you, you should do the liver biopsy to confirm that this is a relapse of the previous tumor. So I agree with you with your algorithm.
No, thank you. Yes, indeed, we, as a professor...
Let me ask Dr. Giuseppe a question.
Yeah, Professor Nagy.
Just because this patient is in the
yes, 70 years now, years old.
Do you have reservations about using immunotherapy, Giuseppe? You have the largest experience with that.
No, absolutely, because unless she has an autoimmune disease, and this is not the case, I don't believe age should be a condition to omit an immunocheckpoint inhibitor. So we have many elderly patients.
No, I'm talking COVID, COVID.
But COVID. She was negative, she performed the test, and she was negative, and for me, it's not a contraindication.
But if she was positive, you would not use immunotherapy.
If it was positive, you cannot use nothing unless you have to give an endocrine therapy. So you wait until it's negative and then you start treatment.
Just a clarification that actually the patient went to her pulmonologist at the beginning, and because her main complaint was dyspnea and cough, Professor Nagy. And having the cough and dyspnea that comes to a pulmonologist at the time that we are now, the first thing that they will do to screen for the COVID-19, the CT chest, and to do the PCR. And that's why the patient did the PCR and it was negative. And we did subsequently the PET scan and the rest of the oncological maneuvers for her. So this is the clarification. As Professor Giuseppe had mentioned, yes, indeed, that we now in 2020, with the era of the immune checkpoint inhibitors, post the Impassion 130, and as well the Keynote 355, that showed that the added value of the immune checkpoint inhibitors in the metastatic triple-negative breast cancer that was actually highlighted and confirmed in these two trials. And as well as Professor Nagy was explaining in his presentation for the PARP inhibitors, the Olympiad and the BRCA, in BRCA, that actually showed as well that patients with either the BRCA mutation or the homologous recombinant deficiency would actually benefit from the addition of the PARP inhibitor to them, whether the olaparib or the tolazarib, and actually it could add to the identification or having more advance of the progression-free survival. Despite this, that actually in with a meta-analysis that the PFS is more having seen with the BRCA mutation, but actually still the overall survival with the two trials is not that much, but there is a trend or a favor for the overall survival. But unfortunately, we did so for the BRCA, it's wild type, and the PDL1 was negative. It was less than 1%. So actually, it's now we are in the point that the patient would actually not being able to receive or will not benefit from the immunotherapy or from the PARP inhibitors. So actually, question to Professor Ala Andil. Would you actually test for something else for the patient, or you will go for routinely?
Well, I will go for systemic chemotherapy plus or minus an anti-VEGF in this current situation. As long, I mean, I was thinking of immunotherapy or a PARP inhibitor, as we all mentioned, but as they are not applicable in this patient, I will go for systemic chemotherapy, whether Gem Carbo or a similar regimen, or the E2100 regimen, Taxol plus Avastin or bevacizumab.
Okay. Professor Yosri?
I've met a similar patient with the same situation, and because of the 70 years and hypertension, and I started for her erbiolene, which is Haloven. And in this situation, I've got a complete response after 3 months of Haloven, and I think this patient is eligible for erbiolene as well.
Okay, that's definitely poor. Professor Amr Lotfi, you would like to comment?
Actually, I have encountered 2 patients of such like this patient, and I have done another thing on the histopathology, because we have 5% of patients with triple-negative breast cancer have an androgen receptor. So I do an androgen receptor for both of those cases, and it was astronomically very high in these cases, and they respond marvelously to total androgen blockade like prostate. So in this situation, I will go for androgen receptors before I start any other thing.
So that's
So this is Giuseppe Curigliano speaking. So this is a first-line treatment, and the role of anti-androgens is very limited in triple-negative breast cancer. So the activity of bicalutamide or enzalutamide or abiraterone is very, very limited. So in my opinion, since this is a BRCA wild type and the PDL1 negative, I would go for a chemotherapy in the first line setting. And as you know, any chemotherapy can be given, or according to the TNT trial, carboplatin monotherapy, because data are quite good, or any other treatment, because there is no standard once you don't have a BRCA mutation or a PDL1 positivity.
I agree, and this is what I mentioned, you know, in the ABC guidelines. Now, she's 70 years old, but she has a very good performance status. So I think, you know, probably any regimen can be used, whether weekly paclitaxel or carboplatin. We like, carboplatin can be very well tolerated, or eribulin. I think these would be like three better tolerated regimens.
Professor Giuseppe and Professor Naji, you want to go for full genomic profiling for these patients?
No, personally, yes. If you look at also at the guidelines of ESMO regarding NGS in breast cancer, there is no indication to perform a multi-test analysis because there will be no clinical implication. So in my opinion, chemotherapy should be given to this patient.
And that's exactly a very good opinion, actually, and that Professor
Giuseppe. By the way,
Professor Amr Lotfi would like to comment on the
for Professor Giuseppe.
Giuseppe.
By the way, the two patients I do the androgen receptor for them, the androgen receptor for both of them was over 90%. So they respond marvelously. This is not the case in another scenario, but these two patients per se, the same like this patient, they both was over 65 years of age, and the androgen receptor there was over 90%.
Actually, as Professor Giuseppe had highlighted that we all will go for chemotherapy. But actually, she is 70 years old, and bear in mind that in the era again of the COVID-19, everyone in the population is afraid of going to the hospital, is afraid of receiving IV chemotherapy, is afraid of being subjected to part of the neutropenia. And actually, as Professor Giuseppe had mentioned, that the NGS exactly is not recommended by the ESMO guidelines. However, there is a special consideration where we discuss with your patient in circumstances and telling her clearly that this is out of the guidelines and out of the recommendations, and it's up to her to go for different scenarios. In general, this patient was insisting to have the NGS because she heard about it, and that's common here in Egypt, unfortunately. But again, we did the foundation medicine, and clearly, as Professor Giuseppe had mentioned, there is no clinical implications if you can see that the only mutations that has been seen is actually showing that there is activity with everolimus, which may be part of the access for the breast cancer, but this is what it comes. Personally, I was not convinced with this, and I guess that we go back to the traditional way that chemotherapy should be the cornerstone for such patient, and that's what, as Professor Yusri had mentioned, all things can be applicable. Every chemotherapy, the single agent is the standard for those patients, and they have been the standard because the single agent would offer the patient the longer time on treatment with good disease control, but then it will relapse at one time. And so that's what we started for the patient, being the age. We went for the Taxol 60 milligram per meter square on the 3-4 regimen. And she started the therapy in July 2020, well tolerated, and 3 months evaluation showed regressive course, and the patient is due for the second evaluation earlier next month.
Why did you reduce the dose? Why only 60 per meter square?
Considering the age of the patient and not to go for higher dose, and this is different, I guess, that as Professor Ala Andil had mentioned, that sometimes data coming from clinical trials for other population would not clearly match on the Egyptian population, and that's a common agreed dose that we use here, despite the 80 milligram per meter square, which is in the adjuvant setting. Professor Hisham?
Actually, 80 milligram per meter square is weekly without interruption, and 90 when you do it day 1, 8, 15, and give them a break for 1 week. I mean, 70 years old is not that old, doctor. Many of us are getting close to 70.
Yes.
Yeah, that's true.
Dr. Emad, may I ask, this patient has only single lesion in the liver.
Two hepatic focal lesions.
So This is a question for all of the panelists, Professor Giuseppe and Naji and all the panel. Do you think that after initial response with the chemo, do you feel that it is important to go for local ablation or surgery for this oligometastatic lesion in the triple-negative breast cancer subtype?
No, this is an elderly patient, so there is personally no data to support a local ablation. So we have some data in younger patients in which you have oligometastatic disease, and if you do a local treatment, you can also improve disease-free survival. Of course, it's a personal choice. So if you have a very good response and only one site of disease, also in an elderly patient, you can do this, but there is no demonstration that is useful in terms of overall survival.
Again, Anna, I don't think this is an elderly patient. She's old, she's 70 years old, but she was in a good general condition. Sometimes, you know, we do that. If she responds very well and we know where the tumor was, maybe a radiofrequency ablation if it's far away from vascular tissues, you know, etc. We usually discuss it in our tumor boards, Hisham, you're right. And sometimes we consider it, but the general recommendation, of course, it's not. But if a relatively non-invasive procedure like SBRT or radiofrequency ablation here is feasible, sometimes we consider it, provided that you really know exactly if she responds well and you know where the tumor exactly was and you can do it. Sometimes.
Okay. So thank you so much for being here. Professor Mohammed Yassin would like to...
Can I have a question for Professor Giuseppe?
Yes,
Yes.
of course, I am here.
As we have seen in this patient, PD-L1 and BRCA was negative, so the decision was to do a conventional chemotherapy. Do you think, based on this patient and based on the positive trials of antibody-drug conjugates, sacituzumab, in heavily pre-treated patients, we can move antibody-drug conjugates in trials for first line?
Yes, I think so, and sacituzumab govitecan actually is going to be tested in the first line setting compared to chemotherapy at investigator choice, because if you have an improvement in overall survival in lines 2 or more, you can imagine that in the first line setting, I am quite sure you can achieve better results. So if a clinical trial was available with antibody drug conjugated like sacituzumab govitecan in the first line, I would propose to this patient also the clinical trial in first line setting.
Thank you very much, Professor Giuseppe.
Thank you so much. By this, I'd like to thank all...
Can I finish just my last 2 slides?
Yes.
Sure.
Just thank you slides.
But you did already your presentation. You completed.
I know. I want to invite everybody to come to ABC 6 in Lisbon in 2021. Hopefully this is going to be our first in-person meeting.
I don't think so, because the pandemic is actually in Europe quite important. And in Portugal.
We hope, and we have a meeting in Beirut in February also, 11-13. I wanted to invite you guys.
Thank you.
Just happy, hopefully we will meet in Lisbon.
Yes, we will.
Take the vaccine. Did you take your vaccine?
I will be there. I will be in Lisbon. Yes, and I got the vaccine.
You got the vaccine. Congratulations.
Yes, I did already.
Good. We're waiting for it here. Dr. Sami got it in Jordan.
Okay.
So
Okay.
thank you so much, Professor Nagy, for the kind invitation. I wish you all a very good day, and hope that we will be able to meet in person once more. We thank everybody, and thanks for the panel, the distinguished panel, for being here, and for those who were all as well on the virtual panels. Thank you so much. Have a nice day.
Thank you. Thank you.
Thank you. Thank you.